Welcome back. Today we will learn a very important topic called thalassemia. Thalassemia. Okay. This is a which type of disorder? It's a quantitative. So what we have another disease in qualitative. If you have not watched that video, kindly go and watch it in this playlist. Under the heading sickle cell anemia, right? So we'll continue with the thalassemia. So thalassemia is a quantitative disorder, right? Yeah. So what happens here? First we will learn what is normal. In normal we have alpha globin, then we have globin, beta globin, right? So in alpha globin we have 4 alleles, in beta we have 2 alleles, right? On which chromosome? On chromosome 16, on chromosome 11. So if something wrong happens, it has to happen within these two. So what happens? So it leads to disease called thalassemia. Okay. So something related to alpha globulin, it has to be deletion of these 4 alleles. Something related to chromosome 16. Then we have, okay, there is a mutation at 2 allele on chromosome 11, which leads to your beta thalassemia. So this is your alpha thalassemia and beta thalassemia, right? So chalo, let's start with the beta thalassemia. We have major, where beta 0 beta or beta plus, right? Which is autosomal recessive. So what is this? No beta chain. This is beta chain present. Beta chain present, but synthesis is reduced. Okay, I hope this is clear with the signs. Then what are the mutations you see in beta thalassemia? First you will see splicing mutation. Just names are enough, no need to go into the detail. Then promoter gene mutation. Then what else? We have third one, chain termination. Okay, so very important thing is pathogenesis. We have beta thalassemia major, where no beta chain, which will be, so there is something you have to replace by something. Okay, so what happens, our body tries to replace it with by alpha chain. And you need to remember, the further problem will be caused by, not because of deficiency of beta chain, it is because of alpha chain, responsible for pathogenesis, right? So what happens? Alpha chain excess, then what happens? It aggregates, right? What happens? Major, there is no beta chain, then alpha chain will be replaced, which is responsible for this pathogenesis, where alpha chain will be excess, which aggregates, right? What it aggregates? Proerythrocytes. So this is your RBC with a nucleus, then we have alpha chain. right? Then what happens? So there is something extra which leads to clump, then it leads to damage the cell membrane, which leads to erythropoiesis. Nothing but abnormality leads to ineffective erythropoiesis. So hope this is clear, right? If something is affecting, that is alpha chain. What happens next? So there is some defect in erythropoiesis. Then what happens? To help spleen and liver are present, right? So we have some other people helping, which are spleen and your liver. So these people, what they cause? Extramedullary hematopoiesis. Very important. So spleen and liver, what they do? They start to produce. What happens then? Splenomegaly. Which leads to extramedullary hemolysis. Okay, this is your pathogenesis. We'll revise it well so that it won't leave any doubts. Then what else? So if there is a membrane damage, by clump, right? We discussed it in pathogenesis. Then what happens? Slight damage. And if you watched my before videos, if I spell slight damage, what it means? Yeah, guess it. You are on the right path. It leads to partial damage of blast. So what happens? Blast becomes smaller. So this looks like smaller and damaged membrane RBCs, right? So this is the reason why you see something very important in your peripheral smear finding. So what is this peripheral smear finding? So there is something small, microcytic. There's something which is defective erythropoiesis. So what happens? Hypochromic, and there will be a damaged membrane which leads to poikilocytosis. So you find this in your peripheral smear. I hope that is clear. If you understand the pathogenesis, you will understand the peripheral smear thing, right? Microcytic, hypochromic with poikilocytosis, not poly, right? Yeah. Then we'll go with the important part. RBC membrane not for all, they are wavy like this. Right? So how it looks like? So this looks like the one you shoot arrow, right? It looks like target cell, right? Target cell, or you call it as a codocyte. How it looks like this? When you watch from top, this is a 2D right? You watch from the above. If you watch from the above, so you will see the target sign, target cell. And if you see this target cell or codosite, then you have to say, yeah, I am on the right path. This is the diagnostic of thalassemia. So this is the diagnostic of thalassemia. Then, okay, we'll see a patient. So how patient looks? Usually he will be asymptomatic till 6 months. Then what happens? Failure to thrive, stunted growth. Yeah, any doubts? You have to see asymptomatic till 6 months. Why? Yeah, you can say that in my comment section, then we will see that at the last. Okay, why it will be asymptomatic. Then what else? Hemolytic phases. This is very important. Like we can say it as a chipmunk phases, right? Chipmunk phases. And one more, crow cut appearance or hair on end appearance on skull x-ray. We'll discuss in a separate video these x-rays, peripheral smears, so that you people won't get confused, right? Just this is a theoretical thing, then we will look into a practical separate practical video, so where you will find every peripheral smears, then bone marrows, then the remaining x-rays and everything, the findings we need to find. Okay, yeah, so these are the 4 things you see like in patient. Then what else we'll see? Beta thalassemia major, we have usually hemolysis, right, which leads to bone marrow compensate, where increase iron absorption from gut, and repeated BTs, which leads to increase iron load, which leads to secondary iron load, overload, right? So in hemolytic phases we'll discuss in a bit detail, right? Hemolytic phases, what all happens, how the baby looks like. Maxilla enlarged, then frontal bossing, then what else, malocclusion of teeth, right? Malocclusion of teeth. So these are the 3 main typical features you will find in hemolytic phases. So we saw clinical features, then we come to lab investigations, where we see first thing, we discussed this in our basics hematology video, why it will be MCV will be less, you can watch into that thing. Then we have peripheral smear, which shows first point we said microcytic hypochromic poikilocytosis. Yeah, then we have target cell from the above. Then we have, since proerythrocytes are like hemopoiesis is affected, so what we'll see, nucleated RBC, where RBC maturation is lacking. right? There is no doubt, I guess, till now. So then what we do? So you found these many things, then we do screening test. Screening test. We take blood of a patient plus blood with hypotonic solution. This is a normal control. This is a test sample. So after 30 minutes, we will take a black lined thing like this. Then we will look into the test tube and both the test tube. So what happens? There will be two, as usual, there will be two features. If RBC lies, black lines will be seen as there will be space created. So it is a normal control. If there is no RBC lysis, cannot see line, which leads to osmotic fragility reduced. So this will be seen in thalassemia. So we will see in the black line kept behind the test tube. So we'll see two conditions where RBC lysis takes place, where RBC lysis do not take place. Just remember the simple funda. If RBC lysis takes place, that is normal. If RBC lysis not take place, then we'll consider it as a thalassemia, right? Hope this is clear, right? So we have many screening tests, but we rely on our better test, right? Which is the better test we discussed in our previous video? Hemoglobin electrophoresis, right? Then what we have, as usual, investigation of choice. If you want more information about this, you can go and watch our sickle cell anemia video, where HPLC is our investigation of choice. So let's see how your electrophoresis looks. Some basic electrophoresis if questions comes on this. First note down, then we will discuss. HbA2 increase in thalassemia minor. Thalassemia minor. Then HbF increases in hemolysis. Thalassemia major, right? So just see, consider this as a electrophoresis, this plate. Okay, we have let's make it as a 3. Don't draw it, you'll get an image in internet or something. Just I wanted to explain you how it will look. So this will be our origin. Consider it as a origin. This is origin. Then here we see HbA2. It will be labeled, right? A2, HbF and HbA. And based on the fixed interpretation, we'll see the findings, right? HbA2 is positive. If it is seen here, if you want in detail, then we'll make a separate video on this, right? So here what we are seeing, HbA2 is positive, HbA is positive, HbA, HbA2. So this will be your beta thalassemia minor, where you see HbA2 and HbA positive. Then we have HbA2 and HbF positive. HbA2, your beta thalassemia major. Let me know in the comment section if you want this in a detailed video, then we will discuss this topic, hemoglobin electrophoresis, right? Okay, so you did investigation, everything you did, then what else? At last we'll do the treatment. So there is something less in the blood, so you have to transfuse the blood, immediate blood transfusion, which is suppress bone marrow, similar to your sickle cell anemia, right? So what is the indication of immediate blood transfusion? You need to know, right? This is important. Indication, it may be hematocrit less than 30 or hemoglobin less than 10. This is the indication. So it deals like you have to do the blood transfusion immediately. So this is about your thalassemia, right? A very important topic. I try to concise the notes as much as possible. If you study this much, I hope it will be maximum sufficient for undergraduates, I guess. Okay, yeah, let's revise very quickly. It's a lengthy video, just see it once, then make a notes properly so that you can revise well. So beta thalassemia, we have major, then minor. Then in major we'll see this and we discuss this in detail. This is autosomal recessive mutation. We have splicing mutation, promoter gene mutation, chain termination. Then we discussed pathogenesis, where alpha chain will be excess, which leads to aggregation of proerythrocytes, which leads to membrane damage, erythropoiesis abnormality, which leads to ineffective erythropoiesis, where it will be helped by spleen and liver, where extramedullary hematopoiesis is seen. At last it will leads to splenomegaly, extramedullary hemolysis will be seen. Okay, yeah, I hope that is clear. Clumping will be found due to damaged membrane, and we'll see due to this pathogenesis, we'll see this peripheral smear finding. What is that? Microcytic hypochromic poikilocytosis. RBC membrane, not for all, wavy, it looks like a wavy, and from above if we see, it looks like a target cell, like this, only this much portion, right? Target cell, or it is also called as codocyte. So this is a diagnostic feature of thalassemia. Then how patients look like, it will be asymptomatic initially till 6 months, because yeah, anyone, it's because your fetal hemoglobin will be present in the babies till 6 months, right? Yeah, very important point, don't forget. Then what we have? Failure to thrive in the baby or stunted growth, hemolytic phases or chipmunk phases, crew cut appearance or hair on end appearance on your skull x-ray, right? Hemolytic phases, features you saw: maxillary enlarged, frontal bossing, mole occlusion of teeth, right? MCV will be reduced. Peripheral smear, we discussed very detailed in above thing. Then we have screening test, we tested like control and test sample. This black line, hemolysis or not hemolysis if happens, it's normal control. If it does not happen, it is a thalassemia. Then we have better test electrophoresis. Then we discussed electrophoresis basics. If you want, we will make a separate video on this electrophoresis if you spam it in my comment section, right? Then we have, as usual, investigation of choice, HPLC. Then what is the treatment? Last but not least, yeah, intermittent blood. Why? What is the indication? Hemoglobin should be below 30, not above. Yeah, it's below 30, right? Don't get confused. Even I am getting confused, sorry. Hemoglobin, it will be less than hemoglobin, it will be obviously less. What is the number? If hemoglobin is less than 30, hemoglobin less than 10, any of the one, not both, right? Or then we need to do, then we have to blood transfuse so that it suppresses the bone marrow. Yeah, I hope this was the lengthy video. Thank you for watching the whole video. I hope we completed together hemoglobinopathies. What we completed? Hemoglobinopathies. I hope that was a concise notes for you all. Kindly subscribe, yeah. I need to say in every video or what? Yeah. Don't forget to subscribe, yeah. Thank you. Thank you very much. Have a great day. Keep smiling. Follow me with the next video, right? We teach every subject. Thank you.